Code dose epi is designed to jumpstart a non-beating heart. It is pure adrenaline at super high doses. If you give this to someone who has a pulse and a blood pressure, even if it is faint and low, you will send them into hyperdrive. And congratulations, the fruit of all your labors has paid off and your patient got a pulse back. Kudos to the team for achieving ROSC following cardiac arrest. Everyone exhales a collective sigh of relief and slowly leaves the room. You are left to settle in for the arduous stuff now. But before you can get to it, you start noticing a downtrending of your blood pressure. And the panic starts to ensue. Now what? Now what? You got to do something quick before you reinitiate the code blue button. You could go up on your levo drip, but what if you don't have it yet or it is already maxed out? This calls for use of a quick fix until you can figure out a longer term solution, and this is a perfect opportunity for use of a push dose pressor. In this video, I'm going to discuss two commonly used push dose pressors, how they differ from code dose carpujets, which one is ideal, how to prepare them, and an ingenious tip on how to set them up for ongoing use until you can get a bag of something hanging. I will also share with you one situation for use of push dose pressors that I do employ commonly outside of the cardiac arrest ROSC kind of situation. If we haven't met yet, my name is Bree. I'm a critical care nurse practitioner who teaches novice ICU clinicians how to handle the daily challenges of life and death in the ICU. Push dose pressor is a drug which is more concentrated than an infusion generally. I mean, it's kind of close, almost close to a 1-to-1 there. But based on the dose of an infusion, it could be significantly more. But overall, it's more comparable to what you give in an infusion and much less concentrated than a cardiac arrest dose of like rocket fuel meant to jumpstart a dead heart. It is generally mixed in a 10 milliliter syringe for quick use. I've only got a 3 milliliters here for demonstration, but I'm going to show you some pictures in a little bit. It's administered in doses of a few milliliters at a time. Okay, first up, let's hit the easy button. If you're working in a hospital, this is probably available to you. I do not believe it is available pre-hospital, but that is the push dose Neosynephrine, aka the Neostick. Neosynephrine infusions are dosed thusly. You get 10 milligrams in a 500 milliliter bag of fluids. Typically it's D5W, which renders 20 mics per milliliter. And it's delivered in rates of 100. Some people go down to like 25, like a sniff of Neo, but super low to upwards of 300 mics per minute or 5 to 15 milliliters per minute. And then it's titrated according to blood pressure. Push dose Neo allows you to deliver more concentrated doses quickly. The dose is 100 mics per milliliter, and some places have this pre-mixed in a syringe. It can be stored in a refrigerator for some time safely. If you need to mix it, take a bag of 100 milliliters of NS, add to this 1 milliliter of Neosynephrine from a vial with a concentration of 10 milligrams per milliliter. This yields you a concentration in the bag of 100 mics per milliliter. Then you just draw up 10 milliliters at a time, label the syringe, and you have a push dose. This allows you to administer 100 mics at a time. You push in aliquots of 1 to 3 to 5 milliliters at a time based on what you need. Pushing the entire syringe delivers 1,000 micrograms or 1 gram of Neo, and this is a lot, my friends. My suggestion would be to instead deliver in the suggested aliquots, allowing time for each dose to reach maybe 1 to 3 minutes, with a duration lasting between 5 and 10 minutes. Note here the mechanism of action. This is a pure alpha-1 adrenergic agonist, which we'll come back to in a minute. It's important. So why is this a great option? Well, it's quick. It's usually readily available. It's ideal in situations of time-limited hypotension, like anesthesia-induced for surgery, procedures, if you gave RSI for intubation, These are time-limited things, and so a little bit of Neo will take you a long way. Or for a patient who's in strictly vasodilatory shock with a lot of tachyarrhythmias. So your patient who's in AFib RVR with the heart rate of 140 and a systolic blood pressure of 70, 60, whatever. So why is this not a great option? Well, in my opinion, if you understand the why over the how of doing something, you retain information better and you eliminate the need to repeatedly memorize. So you got to have a good understanding of the sympathetic nervous system involving the chain of events and side effects that occur once these specific adrenergic receptors are bound. This is critical to attaining a deep understanding of pressors. So I'm going to give you a little overview of this. We're only talking about 2 drugs here today, so we're going to focus on the alpha-1 and beta-1 receptors. So as you can see here, Neosynephrine is a selective alpha-1 agonist, which means that it preferentially binds with just alpha-1. It has no beta effect. So when you have pure alpha-1 agonism, this mechanism is ramped way high. It's an exogenous catecholamine that mimics what happens naturally in our body to clamp down on the pipes. And in this manner, it raises your systemic vascular resistance and increases blood pressure. So it is a potent smooth muscle vasoconstrictor, and it acts on all of these organs, not just the periphery and the vessels. So you get a whole host of side effects. So why is this a great option? Well, it's quick, it's readily available, it's ideal in situations of time-limited hypotension, such as would be induced with post-anesthesia from surgery or procedure, or even your RSI that you gave to intubate your patient. These are time-limited problems. So also you can use it for strictly vasodilatory shock in a patient that has a lot of tachyarrhythmias. So your patient who has AFib RVR with a heart rate of 140 and a blood pressure of 70. Why this is not a great option is because of the same reason why it's a positive, and that is it is strictly an alpha-1. So its effect is going to be clamped down on the pipes, which is fine in all of the aforementioned situations. It ranges from less than ideal to potentially harmful in situations that increased afterload. So examples of that might be like decompensated heart failure with a reduced EF, or shock on top of someone with severe pulmonary hypertension. Right heart failure, profound hypoxia, because again, you're going to further reduce blood flow in the vessels to the lungs as well. Severe bradycardia, because you get a reflexive bradycardia from the drug itself. Hypovolemia, because if you have an empty tank and then you clamp down on the vessels, you are further reducing flow to whatever it's trying to get to. So you got to tank them up first. Or sepsis from ischemic bowel. If you've got dead gut from lack of flow, this drug tends to preferentially shunt blood away from the bowel, the kidneys, and the periphery. So you're going to further worsen blood flow to the bowel and end up with more necrosis and more dead gut. That's a lot of situations, friends. So if you suspect any of these, or if you don't know why your patient is coding, there's a decent likelihood that one of these culprits exists, and you could worsen the situation even though your blood pressure may initially look better on the monitor. So that's the big downside to me. The other downside is it's not available pre-hospital, I believe. Again, correct me if I'm wrong, friends. The takeaway here is it's less than ideal, and I avoid it if I can because there are better options. This is going to be a great time for me to tell you that if this type of content resonates with you, then you're going to love the value that you will receive as an acute care lab member, which is offered on my website at brianp.com, and the description will be below. I do twice monthly live lectures via Zoom with interaction, as well as access to a lot of graphics and PDFs that I create, templates and things for your use. So do go check that out if you're interested. A better option in my mind is the beloved push dose epinephrine. So first and foremost, we got to distinguish this from cardiac arrest dosing. It is not code dose epi. This is not even equivalent to pushing a few milliliters from a carpujet of code dose epi. Let's do some side-by-side comparisons so I can illustrate the differences in doses. So this is a milliliter taken from the cardiac arrest dosing. So that box you're going to open up, you're going to take a milliliter out of it. By the way, this syringe that's in the box is a milligram in the entire syringe, or 100 mics per milliliter. So from this, you're going to take 1 milliliter and you're going to dilute with it 9 milliliters of normal saline, rendering a concentration of 10 mics per milliliter. If you push the entire syringe, you would administer 100 mics of epi, versus the entire syringe of the code dose would equal 1,000 mics, a milligram of epi, right? So it's 1/10 of the dose. So if you take a look at this comparison table that I made, you can see the big time difference between the code dose and the push dose by a factor of 10. It's pretty straightforward, but it's going to vary a little bit based on how much you give of each. Most people are going to give a full milligram of epi when they push it from the code dose box. Sometimes they give portions of it. And as far as the push dose epi, depending on how many milliliters you push. But if you do 1-to-1, it is 1/10 of the dose, significantly less. If you compare the push dose epi to the infusion of epi, you'll see that they're fairly comparable with a wide range. Again, you're looking at an infusion running over an hour over time. Break it down into what you would infuse in a minute versus what you would push in a minute and compare those two. That's the easiest way for me to think about comparing apples to apples. So if you were infusing on the lower end of the epi drip, you'd be giving a mic per minute, which if you were pushing even just a milliliter, you're giving 10 times the amount of the infusion. Versus if you were infusing at 10 mics per minute and you push 10 mics, it's the same. On the higher end, if you're on the max, if you're going up and up and up on your epi, and there is no max on that, but let's say your high end of like 30 and you were only pushing 1 ml from the syringe, it's higher on the infusion by a factor of 3. Hopefully this isn't getting confusing to you all. My main takeaway I want you to notice here is that using a push dose pressor is much more equivalent to what you would give in an infusion, which are both about 10 times less concentrated and powerful than cardiac arrest dosing. And this is going to matter, and we'll tell you why in a minute. Code dose epi is designed to jumpstart a non-beating heart. It is pure adrenaline at super high doses. If you give this to someone who has a pulse and a blood pressure, even if it is faint and low, you will send them into hyperdrive. And a commonly seen side effect is SVT or even sinus tachycardia, 180, 200, super high rates. And you kind of freak out, then you give amio to convert it back. And then if you're not able to wait it out, the dose effects, they could last up to 10 minutes. So you end up chasing your tail at best, and at worst causing harm. So kind of look at this graphic that I created. You're going to give a dose of epi because you see that your blood pressure is starting to drop quickly and you kind of react quickly. So you just tell them to just give a full amp. So then the patient becomes super dynamic, as I call it. The heart rate goes up, the blood pressure goes up. You kind of get a little bit nervous. You look at it, is that SVT or is that sinus tach? I'm not entirely sure. But it likely does have an arrhythmia associated with it because it's very common. So you again push the panic button. So, because in your mind, you're thinking this patient could have a stroke, they could have a heart attack, they could go into cardiac arrest, yet again. So you have two options. You wait it out and let the dose effect wear off, or you treat it. Most people treat it because, again, that panic button is pushed. So they give a bolus dose of amiodarone, 300 or 150. So then you run into a situation where they start to drop their blood pressure because the dose duration of the epi is now starting to wear off. So now you have a double whammy effect of low blood pressure. So it's just like you're circling your tail. A better idea is to slow down, get your infusion, and while you're waiting on your infusion, mix up some push dose epi and give in much smaller doses that a beating heart can handle. What I see a lot in the real world is that instead of mixing a push dose, people will take a carpujet and just push a milliliter at a time. But again, I want to point out this is still delivering a huge dose. You're giving 100 mics at a time from a milliliter of that versus 10 mics at a time per milliliter from a push dose. Factor of 10, okay? All right, I think I've hammered that enough. So let me review just real quick how to mix up your push dose because it's super easy, y'all. Take your carpujet, your cardiac arrest dosing of epi, remove a milliliter from this 10 ml syringe, which gives you 100 mics. You're going to dilute this with 9 milliliters of NS, rendering a concentration of 10 mics per milliliter. Label it. If you push the entire syringe, you'd be giving 100 mics of epi. If you push one at a time, you're giving 10 mics. Okay. Now, note the mechanism of action here. We've got multiple adrenergic receptors that are agonized here. This is a non-selective catecholamine. It's going to bind to all of these receptors. Why is this a great option? Well, you're going to get a more balanced pressor because you're going to get some beta effect as well as some alpha effect. So just like epi and levo are sort of the yin and the yang in the world of pressors. So levofed is also a non-selective pressor. It has a little bit higher affinity for alpha over beta. Epi, conversely, has a little bit more affinity for beta greater than alpha. So you're going to get more, let's go back to that adrenergic receptor slide. You're going to get more cardiac effect when your beta receptors are bound. Increase in chronotropy, increase in inotropy. So you'll get more cardiac output. You will also get more heart rate from it. Because there is less pressure, if you will, on the alpha effect from this versus Neo, you're not going to get quite so much of the SVR effect, which is good in all of those situations we talked about that were not great in Neo. So why might this not be a great option? If you have significant tachycardia or dysrhythmia, this will definitely make it worse. If this could be a myocardial infarction, then higher doses of this will also worsen the myocardial infarction because epi increases your cardiac oxygen demand. Side effects to note, because you see this a lot, epi in and of itself has an independent effect on these problems of hyperglycemia, so you're likely going to be on an insulin drip, and lactic acidosis. It is an independent driver of high lactic acid levels. Another downside is that it does take a minute to make, it does need to be labeled, and not everyone is aware of using this, how you use it, so you may have to take a minute away from the intense situation to do some teaching. So here's my hot tip for how to quickly mix this and leave it so it's labeled for everyone to see, and I just love this strategy. I recently learned this when I was doing an internet search and doing some research for the lecture. I cannot take credit for this, but I am totally stealing it from whoever did it. Take yourself a 3-way stopcock and connect it to your patient. On one end of the 3-way, hook up your carpujet. On the other end, hook up your flush syringe. And then it is labeled for everyone to see and it's less confusing and you can leave it there. So you just pull out a milliliter at a time, mix it with your 9 mLs of saline. Super simple and makes so much sense. Now there is one other situation aside from the hemodynamic instability following ROSC situation that I like to use this strategy, and that would be the slow code. In this instance, you're likely maxed out on all the pressors on all the land. You're entering salvage therapy consideration timeframe. This is also the patient that you are probably having ongoing discussions with the family about goals of care because this looks like it is not survivable. So you're doing everything you can think of to keep a blood pressure. So as you're aware, this is not always a one-time talk. This is often shocking and traumatic, and this family needs time to gather all the stakeholders either on the phone or in person prior to making a final decision. It's rare that you can go in and say, things aren't going well, what would you like to do? And they immediately know the answer. So you gotta give them some time, you've got to give them some illustrations, you've got to do education, you may have to do it multiple times. In that instance, I find that when everyone shows up at the bedside and the blood pressure is stable on the monitor, I find this kind of skews perceptions because they see a nice number and they may have a little difficulty wrapping their heads around the fact that it's taking super therapeutic doses of rocket fuel to get it there, and there are 5 or 6 of them hanging. So sometimes, and this may be considered less than kosher by some people, but I will allow the blood pressure to drop a little, and I will have the nurse repeatedly administering push dose pressors while we have discussions at the bedside, because I find that this is just, it's an unavoidable, like you can't ignore it, illustration of just how profound the problem is, because they can see this person constantly having to give medicine to support the blood pressure, and it can be a very powerful visual. Hopefully that makes things a little clearer for you. If you like this kind of stuff, I do want to remind you, as a member of the Acute Care Lab, you gain access to the visual aids that I showed you today, as well as the rest of them that I created for this lecture, as well as the full-length video discussion on Pressors 101 and more. Thanks for watching.